Welcome back to Between Two White Coats, a podcast designed to help you be the healthiest version of yourself. I'm Dr. Michelle Plaster, a family medicine doctor.
And I'm her co-host, Amber Foster, a family nurse practitioner. In our combined 30 years in medicine, we've seen a lot.
We're discussing key issues surrounding health and wellness, answering some of our biggest questions, overcoming health obstacles, and giving patient-centered advice in hopes of educating you and providing the tools you need to live a healthy life.
If you find our podcast helpful, please consider subscribing so you don't miss an episode. And don't forget to leave us a 5-star rating and review. This will help other people find our podcast.
Thanks for joining us. We look forward to serving you.
Thank you for joining us today on Between Two White Coats. And today we are really pleased to have a third white coat with us, Dr. Juan Lacayo, who is a neurologist, and he is going to help us navigate the world of headaches.
This is very near and dear to my heart, and probably my husband's as well, because I struggle with migraines. I have had them since I was about 10. And so living with migraines and living with headaches, I feel like they're different, and I'm sure Dr. Lacayo will tell us that. But having to kind of rearrange life because my head hurts has been, which I tried not to take off work or tried not to miss school. I had one exam in college when I was in nursing school. We weren't allowed to miss exams, and I went to class vomiting because I knew I couldn't miss. And my teacher was like, "What are you doing here?" And I'm like, "I'm used to suffering through this because I didn't want to fail that test." And she was like, "Oh my goodness, go home. Like this is not normal."
I don't want you vomiting in my
classroom, but it was what I had gotten used to, and so and what I have lived with, and so of course now I have different modalities and different things that I do to help with my migraine symptoms, and kind of know now, like I'm 40, so I've lived with them for about 30 years, so I kind of know the pattern of my migraine and what to expect. But sometimes that's very tricky for people and trying to figure out like, what do I do, and is this normal? And so I'm excited to talk to you today about like what are headaches, and tell us what you know. So just in general, that's a big question.
Absolutely.
Go for that. Good luck.
A headache, anything that hurts from here on up technically is a headache. So some of our most common headaches are tension headaches and migraine headaches, and a headache at the back of the head where there's a nerve there. We call it an occipital nerve headache. And then any other headache will fall into those categories, except for the headache that you get from your spouse. That's a different one. And maybe a headache that comes from the nerve to the face. Quick anatomy lesson is that we got 4 nerves that does the feeling from here on up. 2 in the face, 1 on each side, and 2 in the back, 1 on each side. And so any kind of head pain, no matter where it is, has to go through those nerves. Those are the types of headaches. You want to hear about tension headaches?
Go for it. Let's talk about
Right.
tension headaches.
A tension headache is something that you can have, and it's annoying. It's just there. You can wake up with them. You can go to bed with them. It might feel like a tight hat or a tight band. Maybe like
So
someone
typically here.
Yes.
Is what you're thinking.
Yeah,
Okay.
on both sides, across the forehead, across the temples. Sometimes it could be the top of the head, like someone just put a heavy brick there and left it there. They usually don't interfere with your ability to live your life. It doesn't mess with your vision or your speaking. It's just annoying, and it can go all day long. It could be days, weeks, months on end. Most tension headaches are due to just that, tension, or poor sleep. Poor sleep, if you think about it, is just more stress on the body. So stress and poor sleep probably explain 95% of the tension headaches in my experience. That last 5% could be from, taking too much Tylenol. And now you're addicted to Tylenol and you don't even know it. We call it medication overuse headache. Now, 1% of tension headaches could be a brain tumor. So at some point, if you have them, we should get it checked out. Try to figure out what's the cause. Is this stress? Is this sleep? Are you taking too much of any over-the-counter medicines, or do you have a brain tumor? So that's what we got to figure out with tension headaches, which is different from a migraine headache. A migraine headache is usually one part of the body. One part of the head. It could be on the left side or in the front or in the back. It has more of a heartbeat in your head feeling, where it's pounding, it's throbbing. You start getting sensitive to extra stimuli, get sensitive to light, noise, movement, commotion. They usually hit for hours at a time. Sometimes they can go for a few days, but when they hit for hours at a time, the criteria is at least 4 hours. And sleep may help. So most people will try to find a dark, quiet space to try to sleep them off. And that's what migraine headaches are. And they can be severe. They can be debilitating. What a lot of people have already known if they have migraine headaches is, let's say you have a migraine on a Monday. You go to sleep, you're able to sleep it off, but Tuesday you have this migraine hangover.
Yes, you do.
Yes, feeling foggy.
Like a foggy, yeah.
Feeling just not quite right, not quite sharp, and you got to go to work then, feeling a little foggy-headed in that respect. There's a third day I like to describe to patients where the migraine is kind of hovering, is sitting there, threatening. It doesn't hurt, but it's sitting there. And even with that type of headache, you could, maybe not be in pain, but it still interferes with your thinking or your speaking. So if you're talking about one migraine, you could have the threatening day, the migraine hangover day, and you can see easily how that one migraine could take 3 days preventing you from living your life.
With migraines, people will sometimes get nausea and vomiting. Other ways that people might distinguish whether they're having migraines versus some other type of headache. Everything you've described, I think the pulsatile, the pulsating headache is one that kind of stands out for me, or more like on one side or around your eyes. Sometimes people will describe. But I find that patients have self-diagnosed their headaches, where they'll come in and tell me, I have terrible migraines. And sometimes they're right, many times they're right. But if people are trying to kind of piece this together, other characteristics?
That's a great thing we bring up, because some people say I have a sinus headache. When all has been said and done, brain scans, nose scans, all the kind of scans, that most sinus headaches ends up being diagnosed as migraine headaches. So most people who say I have a sinus headache, usually it's going to be a migraine headache.
Interesting.
And so migraines, we're going to have maybe sensitive to light or noise or movement, sometimes all the above. Sometimes there'll be triggers if people can put it 2 and 2 together, saying, I had a migraine. Well, I ask you, what did you eat or drink 15, 20 minutes before? A lot of times it's not obvious until you keep doing it and then realize that this is what it is. Some people could live years of having a migraine trigger and not knowing it. And so those are migraines. When you have the major criteria for it, it often will cause nausea and or vomiting. I've experienced migraines myself, and unfortunately never got to that point. I had nausea once, and I was not a fan of it, not at all.
Yeah.
And then the timing of it. So 4 hours or more is what a migraine has. Sometimes you do not get a warning. Sometimes you get a warning. That warning could be these little flashing lights in your vision, maybe some numbness or tingling somewhere, occasionally difficulty getting your words out and talking. If that happens and you don't have a history of migraines before, it's actually important to make sure you get checked out for a stroke first.
Right.
Something that a lot of people may not know is that when you have migraines, compared to someone who doesn't have migraines, that someone with migraines is twice as likely to have a stroke compared to someone who doesn't have a migraine. But once you get checked out and you realize it's not a stroke, then we realize this is a migraine. And to have recurrent migraines, people just need to have maybe 4 throughout their life. If you have 4 throughout your life, we consider ourselves lucky sometimes. Occasionally we have 1 every day or 4 a week, or what's less likely is 2 in a day, because once you have a migraine, it's pretty much going to be an all-day affair.
And I think one of the things about headaches, just in general, is that, if your thyroid is off, we can do lab work. But migraine or headaches is very subjective information. And so your pain tolerance and my pain tolerance may be different. So sometimes I think that's difficult for patients too, because like when you were saying about the speech, sometimes my words will come out crazy. Like my kids are like, oh, mom's got a headache. Like she's talking crazy. And it's just because I'm not getting the right word out. And that would make you think oh my goodness, what is wrong with my brain? It makes you feel crazy. And so to have subjective information is hard, especially if you're trying to diagnose and treat them.
Yeah, absolutely. And so you're really relying on, I'm going to have to ask you all the questions I can
Yeah.
think of to try to figure out what is this headache. And a lot of people have difficulty in describing what they're experiencing.
With men, and I don't know, like, and I haven't read about this in a while, but migraine headaches versus cluster headaches, are, I know they're in the kind of same quote unquote category, but how would you differentiate like a cluster headache versus a migraine headache?
Yeah, some people say I have cluster migraines, and I think they're just kind of putting those terms together in their head. A cluster headache is different. You know, the other category is like when you have one of the nerves of your face acting up. The nerve at the back of the head is an occipital nerve. So when it's causing pain, we call that an occipital neuralgia. The nerve at the front of the face, we call it a trigeminal nerve, and sometimes it can act up on its own, and we call that trigeminal neuralgia. But you have these headache types like cluster headaches, which travel in this trigeminal nerve and causes the symptoms.
That sounds horrible.
It is, because a cluster headache, the reason we call it a cluster is it clusters up a few days in a row. Oftentimes it'll hit people in the middle of the night. It will last for 90 minutes, 2 hours long, and then disappear. But for those 90 minutes to 120 minutes, there is no way. There's no way to make it feel better typically. It's not like a dark, quiet space is going to work. No. People with cluster headaches are usually pacing around the house, trying to put their head under a pillow. Maybe I'm going to bang it against the cupboard. I'm going to put some ice on it. I'm going to hit it with the hair dryer. And a lot of times they just don't get any relief during that time when it's hitting them.
Completely different. What other types of headaches? I mean, you kind of ruled out our sinus headache theory, so
Right, but a lot of
I know,
patients
right?
will
Say
say
that.
this
They're
is
like, I got a
sinus.
sinus headache.
Uh-huh.
Let's hear it all the time.
I think the first kind of headache that I don't think I heard about in training that I saw in real world when I became a full doctor was where someone had a migraine and I treated them with the appropriate medicine and the migraines went away. And then they started complaining that it felt like a little pin, like a little needle was jabbing them in the scalp in different areas. And I wasn't quite sure what this was. And then I went back to a textbook, and there was one paragraph that says stabbing headache. You know, so it's a idiopathic stabbing headache, meaning it feels like a pin on your head, seconds at a time, and disappears, and we don't know where it comes from.
Wow.
You know,
Yeah, I don't think I don't even remember.
don't-
There's the things I remember forgetting. That's not even something I remember forgetting.
Right.
Right. Yes.
When is a headache a medical emergency?
When it's a new headache is a concern for anyone over 50. You know, because at age 50 and you never had a headache before in your life and now you have one, we have to be worried about, have you had high blood pressure that you really haven't addressed? You know, is that making it where you have an aneurysm, a little bubble building up in an artery? Is there a brain tumor? You know, if you have the worst headache in your life, you know, some people may have had a migraine since they were 12 years old, but for some reason one day when they're 40, they have the worst headache they have ever experienced. They're describing it as like an axe to my head, and it never hurt like that before. Those are some of the bold words that when they're describing it says that we got to get this checked out.
The things that always make me nervous, as well as everything you've just said, if someone has worst headache and vomiting, is sometimes increased intracranial pressure can create that kind of vomiting, so bleeds or things of that sort become worrisome. Or if there's any other neurologic deficit, like a change in vision, that can happen with migraines or other things. But if someone says I'm suddenly seeing double, or of course with slurred speech or weakness or anything else that seems to be coming on with the headache, always makes me more worried as well.
Yes, and there's a unique thing about migraines is migraines are where there's brain cells that aren't able to do their job. That means they can occur with pain or without pain. And whatever brain cells that are being affected, they can't do their job. If it's the brain cells for your vision, there goes your vision. If it's for your speaking, there goes your speech. If it happens to be your attention center, your alertness center, you can pass out from a migraine. If it's the movement centers, you can get paralyzed on one side from the migraine. And so we call that a hemiplegic migraine, and it can affect people at any age. When it affects them, it will be a week typically before it resolves. A week's worth of being weak on or paralyzed on one side of your body from that kind of migraine. So migraines can do anything.
Yeah, you would literally have to come visit me at home if that happens. I'm just gonna absolutely.
Absolutely.
Like, Shelley,
I'm there for
Shelley.
you. And all those things present the way that I believe we end up with that diagnosis of these really interesting presenting migraines is to rule out all the other stuff.
Absolutely.
And migraines can be frustrating in that respect because they can look like so many other things when they're not presenting with actual pain, when you don't so much have the headache but you have neurologic loss.
That's right.
And that's when we're so very thankful for you.
Yeah.
Actually, that's why it's important if someone has some of these new symptoms or weird symptoms with a headache or without a headache, they get checked out first. They get checked out first in an urgent setting, in the emergency room, call 911. Mm-hmm. Later on, it will be good news to say this wasn't a stroke or a tumor, but this may be a migraine. Some of my patients who may have a hemiplegic migraine, I tell them to go to the emergency room twice. For the first time it happened, then they're seeing me, and I ask, the next time it happens, I want you to go back again. And on the third time, okay, I think we know what we got going on.
Right, because we don't want to call it a nothing or a less when we're still not sure.
Correct.
I think sometimes the fear is, Amber's kind of joked about this, that if you've had migraines and you have these interesting symptoms, you'll consider it your migraine when you could be having a stroke
Something
and never
horrible,
know it,
yeah.
because you're going to contribute it to the symptoms that you get with your migraine. So I think better to have it checked out and make sure.
Yeah. What are and obviously I'm talking about treatment modalities, so I know some of the newer medicines I've been really excited about and have personally taken, and it really has made a huge difference in my life. But what are some of the treatment modalities, like things, medication, any other type of interventions that you guys suggest or would say, hey, maybe try massage or try, I don't know, whatever else, relaxation, meditation, whatever?
It's great. I think for migraines, we have so many more options now. For tension headaches, it's get to the root of the problem. If it's not sleeping good, fix it. If it's worrying about stuff, fix that. When it comes to migraines, classically we say it's because the brain cells are acting up, they're misfiring, they wear themselves out, and that's what a migraine is, and all the symptoms that come along with it. So if we are talking about preventing migraines, step one is eat right and exercise.
This is a recurring thing we love to talk about.
That's correct. Step two is making sure that your nutrition is adequate and paying attention to when you're getting them. I like chocolate, probably like a lot of people. And I didn't realize one day where after Halloween, and I didn't let my kids eat their Halloween candy.
You picked out the good stuff.
Because it's bad for them.
It's bad for them. So a lot of times I'll put it in a big bowl and just bring it to the office and let people pick at it. It's good for the spirit in the office.
Morale.
Yes, but one day I was just in a rush and I said I'll grab this little ball of chocolate that has that little cellophane, or excuse me, the tin foil around it. And I opened it up, ate it, and then 15-20 minutes later I could feel the migraine coming on. And that's where I realized that fortunately my trigger isn't chocolate, it just happens to be maybe that high preservative containing chocolates. Because those chocolates were meant to last forever.
And they do,
and they do.
Yeah.
But they also give me migraines, so I'm not touching those again.
Right. And it is important. We'll ask people to do headache journals or headache logs and kind of look back at what may be triggering your headache. And people can sometimes find patterns of something they're eating or something that happens that may be a trigger for them.
That's right. It's good to keep track of it so you know what your triggers are. So avoiding those triggers hopefully is a way you can prevent migraines. Most of the medications we have are to help stabilize brain cells so that they're not going to be so hyperactive, which is what the migraine phenomenon is occurring on the brain. And so the medicines have been like that. And the medicines we've used for decades have been anti-seizure medicines, anti-depression medicines, or high blood pressure medicines. And so they were used for something else, and we used them in migraines, and they can be helpful. It's the first line of things that we try, but it's always been medications designed for something else that we're extrapolating over to migraines. And a lot of these medications, or all medications, have the potential for their own side effects. The nerve of the face, call that trigeminal nerve again, when it gets activated, it releases a little chemical. That is something that they've learned 20 years ago, but only the past few years they realize that when that face nerve activates, releasing a chemical. That chemical will transmit signals to the brain, and the brain will actually turn into a migraine. So if you block that chemical, you can block the migraine. And so that's where some of these new medications are. They're blocking that one chemical that has a really long name for it. It actually doesn't have its own name. The name for it means it's close to another gene present, and we have it called CGRP for short. So we're blocking the CGRP with these new medicines, which has been game changing because they're medicines meant from the ground up to treat migraines. Some of them will prevent migraines. Some of them will treat each migraine as they occur. And there's one that actually has indication for doing both. But the side effects of them tend to be very mild because it's just blocking that inflammatory chemical and is doing very little to the rest of the body.
So when do you change from the more traditional migraine medicine? So if someone is listening and they've been on a blood pressure pill like propranolol to prevent their migraines, or they're on other older medicines, when do you switch them?
When insurance says no.
Yeah,
Right.
that is always the
so
answer.
true.
Exactly.
No, but what happens is most insurances says this is what we've been doing for a while. You've been taking these medicines, keep taking these medicines. You got to go through 1, 2, sometimes 3 of them before they start opening up for newer medicines.
And so from a neurologist and headache expert standpoint, would you start people on the newer medicines right off, or are there some of the more traditional medicines that you feel like, well, these medicines are superior or just as good?
It depends on the individual, but for the new medicines, I would start them from day one. I really would.
And we find this a lot for people who aren't familiar that to get a prior authorization, everybody knows what a prior authorization is because they get told your doctor can do a prior authorization. But we can do lots of prior authorizations. It does not mean the insurance is going to approve the medicine. And so you have to often show that they failed a cheaper medicine, which is typically then the older medicines that maybe weren't as specific to migraine. And sometimes a fail can be that their headache wasn't well controlled on it. And sometimes a fail can be that they're having intolerable side effects. And so some people's blood pressure will go too low on propranolol and they stand up and they get woozy or feel lightheaded a lot, or they'll have other intolerance to topiramate, or and maybe they've been dealing with it. They feel lightheaded all the time, but now we do have some other options. So it's worth the discussion to say maybe I don't have to take this medicine. Maybe there's something better. And then what about the triptans? Traditionally, Imitrex, sumatriptan, and all of the other triptan-like medicines have been our abortive medicines for migraine. So once you get a headache, this is what we would suggest if people could tolerate those. What patients who have been using triptans might want to consider whether these newer medicines might be the right answer for them?
Yeah, that's a good thing to bring up because a lot of people who take the triptan class of medicines, and I think there's at least 9 of them, is that they have their own risks for side effects. Sometimes it can raise blood pressure. So if someone has high blood pressure, we might want to avoid it. They cause vasoconstriction or tighten up the arteries, and that's probably why it's raising the blood pressure. And so people who have any heart disease or coronary artery disease, we might want to avoid using triptans for those people. They do work on the brain chemistry, and some of that makes it where your face feels hot. You feel like elephants sitting on your chest. It feels like elephants just squatted on your head. And so a lot of those side effects can occur with the triptans. If they work without side effects, fantastic. But if they partially work, that means that maybe I went from a 10 out of 10 migraine, I took my triptan, now I'm at a 5 out of 10, but you still have the headache. So that's another person who would be a good consideration for trying one of the newer medicines.
With the triptans, I've taken them personally, and if I took that, I would not be able to come to work. It made me very, very sleepy. Now, it would be great for when I needed to sleep off a migraine, but to be able to come and function, I couldn't do that. So the newer medicines have really helped me with that, and I haven't taken them in 2 years.
Yeah, I think that it's a really frustrating balancing act for people who struggle with migraines because they are trying to go about their life. And if people have repeat migraines, they end up missing a lot of work or having other things that they're missing out on. And so then you're in this balancing act of, well, do I just go to work with this terrible headache, or do I go to work and take my triptan and I'm sleepy and kind of out of it all day?
Space cadet. That's what I call myself when I do it.
And some people can tolerate the triptans and be very functional, but some people are very sleepy or not functional on the triptans, which, like you said, if you're going to bed, that's one thing. But if you have to
little
go to
children
work,
or going to work, like you don't want to feel like that.
Yeah, and so I think for people to know that there's a lot of newer medicines out there, and if you have, a lot of people have, like Amber said, have struggled with migraines for a long time, and so you find something that is good enough. And if you're in that sort of, this isn't great, it takes my headache from a 10 to a 6 where I can go to work and function, but it may be worth a discussion if you haven't talked with anyone about your headaches in years, because there are so many other options available now.
Absolutely.
Which you said that was like one of that's the number one thing that you see, right? In your practice. So you talk a lot about headaches.
Yeah, I do. I could recite this in my sleep over.
Yeah.
Yeah. And headaches are common.
Yeah.
Headaches are a common problem, and people tend to come and see us when things hurt.
Yeah.
People don't come and say, you've got to fix my blood pressure as often as I say, you've got to fix my headaches, because it's terrible to be in that kind of pain. So I think some of the important take-home messages are, there are some headaches, and it is not the overwhelming majority, but there are some headaches that are medical emergencies when they come with neurologic symptoms, when it's the worst headache of your life. And we would rather you have those looked at before you say, oh, it's a migraine, or it's a, we need to rule out the bad stuff in those really bad headaches. And then there are a number of more common headaches, tension type headaches, where it feels like you're getting your head squeezed. And that there's a lot of over-the-counters that you can use for those, and most people will start popping those over-the-counters a little too liberally. And when people have had a lot of tension headaches, we often will find that they've now induced a prolonged headache by using too much of the over-the-counter headache medicine. And so don't think because you could buy it without a prescription that it doesn't potentially do some harm. So be careful of overuse of those over-the-counters on your tension headaches. And then migraine headaches that are very common. And that we have a lot of new treatments for, which is very exciting. I think one of the more exciting things that's happened in medicine in recent years is all of the advancements in migraines. And if you are struggling with headaches, that there's a lot of help out there for you. Mm-hmm. Any take-homes on headaches that we want to make sure people are taking away?
I think it's important to know that every time you have a headache, that you're being robbed of living your life. I think a lot of people, including myself, who've had a migraine, there's been a moment where we might have missed a kid's practice or a kid's recital, and if there's ever a time where a family member says, yeah, I remember that time I did this, but you had a headache, it's like we need to treat them.
Yeah.
We can treat them, we can treat them well, and that we really should seek all options available to us to do so.
Thank you for saying that, because I think when people struggle with anything, it becomes their new normal. And it doesn't have to be. There's a lot of help out there. And so thank you for helping that call to action, that if your headache is keeping you from living your best life, then see one of us white coats so that we can help you with that. Thank you so much for joining us today.
We like to end you on a good note. Today's Tell Me Something Good is staff babies. We have several staff members that are pregnant. We are so excited to add these new little teammates. Thank you for joining us today, and until next time, take care of yourself.